Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And in this new healthcare world that we are dealing with, information and tools that you can use to improve your healthcare are really going to be very important. So the topic of our presentation today is consumer alert. Everything about healthcare is on the internet, or is it? So we're going to be challenging some of these assumptions today because our guest, who I will introduce in a moment, is an expert in communication. And she's going to be sharing with you some of the research that she and her company have done that really have elicited the following information. The fact is that when they looked at the internet, they found that there was a lot of information that was missing. So sometimes you would go on and you would think you were getting a complete picture, but some of it was missing. The other is that it was incomplete. There would be things that were not even addressed, things that you would need to know, but that you really couldn't even find the information. And then third, and we know this from our own work in healthcare, a lot of this information can be very uninspiring. You're really just getting onto the internet because you need to for some particular reason, but you're not really necessarily enjoying it and finding it inspirational. So let me introduce our guest today, a friend and colleague who is visiting with us in Philadelphia from Chicago, Dr. Sylvia Arrufo. Welcome, Sylvia.
Thank you, Nancy.
Let me tell you a little bit about Sylvia's background, because her background, as she is the CEO of Communication Science, is rich, and she has a whole body of knowledge that she is using to inform all of us in healthcare about how we can do a better job in patient education. Sylvia's background is that she started as a person at Baxter who worked with consumer-facing work, so that they really did work with consumers through Baxter, and she headed up a whole division. Before that, she worked with the World Health Organization in the area of health literacy, which is an area that helps to translate complex healthcare terms for regular people. So being able to take information worldwide and help people take better care of themselves was really the focus of her work there. Prior to that, she was working in consumer experience work, helping consumers to have a better appreciation in 2 companies that you've heard of, General Motors and Pepsi-Cola. She has a PhD in ethno-linguistics, she has an MBA and an undergraduate degree in not communication science, but in behavioral science, and also one in a term that she will be explaining to you, ethnography. So she's extremely well educated, and she is a joy to work with. I had the pleasure of meeting Sylvia and some of her other key staff almost 10 years ago. And when we get to the point of this discussion where she's going to be showing you some of these kits that you're seeing in front of us, I can tell you when I first saw them, as a nurse, I thought they were the best tools I have seen. Because I will get into this more as we go on in the show, but healthcare providers need tools that they can use with patients, because the way it's done now is rather haphazard, and we'll get into that. But let's start with your work, Sylvia. Again, thank you for joining us, traveling so far to be with us. And tell us about your research and how that really helped you to address these areas of gap information that isn't there, and how to inspire people to do a better job.
Sure. It really does start with the ethnography, which are the field research techniques of anthropology. The same kind of activity that you've probably heard of Margaret Mead going to the islands in the South Pacific. There she studied people's beliefs, priorities, what they thought about, what they valued. This is something that has come home, and we're now doing that same kind of anthropological work on subgroups in our own population. Many companies think of their customers as a subgroup, a culture that shares values. That's why they all choose to drink Pepsi or drive a Chevy. It has something to do with who they believe that they are. So that's where my work started. Now in healthcare, Baxter Healthcare recruited me to do this same kind of anthropological work on patients. What do they have in common? Because a whole group of them have diabetes or hypertension or have undergone surgery. What are those beliefs and values that we should be reflecting in the education that we give them?
I think I'd like to just underscore that point, because in our field, we need to really be drawing from other experts in other fields. So for instance, in Pepsi-Cola or General Motors, all companies, quite frankly, are very attuned to this. They just don't see everyone as one major item in a herd. They try to cull out and figure out, what is it that's going to appeal about our product and service to certain groups, as Sylvia's just been educating us about. In healthcare, we really haven't been that sophisticated in really understanding all these subgroups and how we are going to approach different groups and different disease entities so that we can be more effective in our education, and that's part of what we're addressing today. So thank you.
Yes. Well, one of the first things I'd like to tell you about in doing this research, what we do is to go into the patients' homes. We don't invite them to come into a focus group. We go to where the people live and work. We shadow them through their lives to understand how they make decisions, what they look for in healthcare information. Where do they go? What resources do they rely on? In doing that, we found some gaps. Very interesting things that you wouldn't think, because everyone says, oh, it's all on the internet. Well, maybe not. One thing we found that's absolutely missing is how medicines work. Now, the reason that this is critical is because we know from the data that's clearly available from prescriptions and refills of prescriptions is that 70% of people do not take their medicines. That's a critical feature for the whole society. If people who've been prescribed something are not taking their medicines, why are they not taking them? Unfortunately, I'm so glad you said that about there's a lack of sophistication in healthcare and understanding the patient. There is a test out there on why don't people take their medicines. It's purported to be validated and reliable statistically, but the main question on that test, why didn't you take your medicines, only gives you 3 options for an answer. Was too expensive, I forgot, or I don't like the side effects. Those are the only options for an answer.
And you're saying that it could be much deeper than that. There
Much
could be
deeper.
other reasons that we never even get to as to why people don't take them.
And the reason that we found, and I'm sure when I describe it, you'll resonate with it. I know you, Nancy. The main reason why people don't take their medicines is they say, I don't know what it's doing in there. I don't have confidence of what these chemicals are doing in my body. I don't want to take drugs. That we found is the deepest level, and people cannot get the information about what this pill does once they swallow it.
Right. So given the fact that pharmaceuticals is one of the largest cost factors in healthcare, the fact that people aren't taking their medications is not a small item. So if you're saying that if people had a better understanding in ways that they could understand, they would be more likely to take it because they could see the value.
Right.
Right now, what you're saying is people are fearful.
Absolutely.
It's the fear that is whatever fears. They may not even be able to articulate those fears.
Yes.
But there's just something that says to them in their inner voice, I don't want to take this.
Absolutely. And some of the things they do articulate is they try to ask their providers, what does this drug do? And they don't get an answer. Our anthropologists have gone to doctor's visits with our patients who are subjects in the study. A patient will ask, like we had one, I like to call it Barbara and the beta blocker. She got a prescription for a beta blocker and she asked her doctor, what does this do in my body? It says blocker, what does that mean? And the doctor said, in front of our anthropologist, just said, it's for your heart. And she went out to the nurse on the nurse's station and she said, what does a blocker block? What does it do? It's for your heart. No answer at all.
Right. Which probably is the fact that both of those providers in that one example just feel like if they get into the deep like chemistry of this,
Right.
the average person isn't going to understand it anyway, so they just keep it so simple that people don't understand it either. So it either is too simple or it could be potentially too complex. So,
Right.
So how have you addressed that? Can you have an example of that?
Yes, what we have done actually, when we went on the internet to see if we could find anything at a very popular website, one that you would think would provide this information, what we found instead were just classifications of drugs. And the definitions of those classifications, I think, fall into the same trap you said about trying to be simple. They become vague. So what we have done with my team of nurses and anthropologists and sociolinguistics, we sat down with the FDA submissions for 134 of the most commonly prescribed drugs. We read the section of the FDA submission that goes into all the chemistry called the mechanism of action, and we translated that into little 30, 40-second segments that use metaphors to describe what the drug is doing in your body. I'd like to show you an example of one right now that I think you'll enjoy.
Oh, that'll be fun. Let's take a look.
I actually tried it myself. I experimented. You know, I got a McDonald's hamburger with fries, and the next day I was tired and weak. The next day I ate vegetables and stuff. I had veggie meatballs with sauce, and I felt really good, and I didn't eat them all. I only had like several portions of them, and I felt great the next day. You know, I did my own experiments. I did my own experiments. That's the only way you're going to learn, because you've proven it to yourself.
Now, Sylvia, when you show that to most people, what is their reaction?
Oh, I'm so glad you asked that. They laugh, they are relieved. In fact, one of my nurses showed this at a conference, and everyone in the room was so astonished that we could bring humor to the process of taking a pill that they clapped, just spontaneously clapped.
So that was a room of healthcare providers?
It was.
Yes, we can be a very serious crowd, and it's good that you could at least give us something to enjoy, as well as to see a different angle on education.
Yes.
So after they left and they clapped, what was the response? I mean, did they sort of get it?
Well, we have these available, and we have a long history now of how patients respond to them and their compliance increases. What we hope is that people will want to have this available for their patient group, whether it's a health plan or a hospital or a home care agency. This is where we're going with this program of being able to explain 134 most commonly taken drugs.
That's very interesting, because as Sylvia referenced the FDA, Food and Drug Administration. In those applications, it is extremely detailed in terms of the action of these drugs, what they actually do, because that's all part of the application process that's reviewed by experts at the government level. But to take that and translate it down to something that, as you say, using metaphors and just a small tape that we just saw, down to something that really helps people to understand what a drug will do. And if they're relieved because they feel like, okay, now I sort of get it, I understand, you know, what even part of the body it's working on. I mean, I've gone through this with my mother. I've gone through her list of drugs, and I've had to explain to her, well, this one is for your heart. This one is for your blood pressure. This one is for your other areas. I'm not going to get into all of them, but you know, I would have to go down through each category and try to explain it to her.
What you're doing is, we found that almost all of our patients were puzzled and frustrated that they were given, say, 3 drugs, but they're all for diabetes. Why do I have to take 3 drugs or 5 drugs if they're all for my heart? But that's the only answer they seem to be able to get.
Right.
This will take them the next step.
So this is a work in process for you to put all this kind of packaging around understanding what all these drugs do. But that's really a wonderful thing. And your early experiments, you're getting very good results with people really, again, increasing their compliance. So this is something that really all of us Whether we're consumers, we certainly want to do that, but if you're working for a drug company, I think you'd be very interested in this kind of information. Healthcare providers would be very interested, because there's no use writing the scripts and people then spending the money and getting these drugs and then not taking them. And that also confounds when you go back for your follow-up visits, if you're not taking the meds or if you're taking them sporadically. It's very hard for any treatment team to understand what your progress is. So the other piece of this that I don't think Sylvia has really said is a lot of times people don't want to really fess up and tell their provider that I haven't taken it. You know, they just like sort of gloss over it. So that even complicates the whole picture even more. Right. So proceed. What else?
Okay.
What else?
The next category I'd want to talk about is when there's information there, but it's incomplete. And I'm glad you raised originally the idea of how information can be very vague. In the name of making it simple, it becomes vague. I'd like to show you an example, and this often relates to treatments.
Okay.
There's a knowledge on the part of the provider that they must explain the treatment to the patient, but these explanations are often incomplete. Like the one on the screen right now is from a very prestigious institution in the United States attempting to explain radiation therapy. This is just the first paragraph of it, but you can see two problems with it right up front. One is that the first sentence says basically, radiation therapy is radiation. That really doesn't tell you anything. Then you can see at the end of the paragraph, it basically cops out of explaining it to you and says, don't worry, your provider will choose the best radiation therapy for you.
Right.
Now that's not part of the new paradigm of healthcare.
Right. I think the slide that you're looking at now, you may not be able to read it, but it is very dense, and that tends to be the way these come across, and they go on for pages and pages. Yes. This is just one paragraph. But I think the point that you made, that to try and explain something by saying radiation is radiation is really not very, very helpful, especially for people that really don't even know what radiation is to begin with.
Right.
So
that's a good entry to talking about how we do our research, because we start from the premise that when you get to be an adult, you have a basic knowledge. Even if you might not have as much education as the next person, you have a basic knowledge of how the world works. And what we want to do to build these explanations is to find what you already know and then help you take one step further to understand the new information. So continuing with the example of radiation therapy, what we have for our explanation, you'll see on the screen now, and you might not be able to read it, but I'll describe it to you. We start right out with something familiar. We say, radiation therapy is X-ray. And you know that X-rays are radiation because anytime you've ever gone to the dentist, they put a radiation shield on you and the therapist goes behind a door.
Right.
So you know that X-rays are radiation. That's something that's familiar to you. Now we're just going to take it one step further. Instead of using X-rays to take a picture of your body, we're going to use X-rays focused into a point to treat a tumor in your body.
So is that what we're looking at now?
Yes.
Okay.
And what you'll see is, again, we relate it to something familiar, taking a magnifying glass and focusing the rays of the sun on a paper and burning a hole in the paper. That's what we're going to do with radiation therapy on your tumor.
Okay, so what you've shown us in this slide is the alternative to a very densely written piece, and one where you're really using pictures to illustrate the point.
Right, pictures with familiar images.
Okay, so that way the person comes away from reading this and has some explanation that it really expounds on what they already know.
Yes, and it relieves fears because it makes it familiar.
Okay.
I've been to the dentist 1,000 times. That's what it is.
Okay, all right. And what's the response once people see this kind of thing? What do you see the patient's response?
So much stress goes down. And by the research, we also find out what their fears are. And as a clinician, you might never think of it, but there's a tremendous fear out there that if I'm subjected to repeated radiation treatments, am I going to become radioactive? And in our explanation, we're able to say no. Just like you don't become radioactive from the x-rays that they take at the dentist. When they turn off the machine, the radiation stops.
Right. So I think that the takeaway from this and from the slide that we just looked at is that even for well-educated people, I don't think it's even a question of education. It is a question of really making the association between what you already know and then having this kind of approach to education that really helps you to target it, that information and whatever new information you're reading about, target it to your situation so that you have a better understanding of what this means and then therefore why you would be having certain treatments or what would be the next step in your treatment plan. So it's not a question of just being a highly educated versus less educated person. Frankly, I think that even very highly educated people, when they are in a high stress situation like getting a very difficult diagnosis or knowing that their life is going to have to change or accommodate a new set of tests or procedures, get highly anxious. And that really blocks even the information they already know. So this is really a very good approach for everyone, not just a certain population.
We believe that deeply. And the third thing that we've found is missing, and that is inspiration. We have found that as we sit with the patients, watch what they do, see their reactions to handouts they get from their providers. Essentially, well, for example, if you have hypertension, it's very likely that you have seen at one time or another a drawing something like this.
Okay, let's take a look at that in our next slide.
And it shows you a cutaway diagram of body parts. These are your arteries with and without cholesterol.
Okay.
This is very accurate. There's no question it's accurate, but it's not very inspiring. And let me show you what I mean. What we do in our explanations is we use the metaphor, as I've said before. What we say, instead of saying that your arteries look like these two circles, we say your arteries look like this.
So let's take a look at that. Oh, that doesn't look too good. What is that, by the way?
That's a hand covered with gunk, and your arteries are covered with gunk. This is the way you should think about it when you are tempted to have that hamburger with fries. This is what it looks like when you're done.
So when you have that hamburger and fries, it turns into that green gunk somewhere in your
it.
body.
Yep. So that's how we want to inspire people, with very powerful images rather than cutaway diagrams of body parts that seem very abstract and distant.
Right. I think that for most healthcare providers, I've been involved with patient education in any number of situations. We go back to our own textbooks. I mean, that's how we learned. So we don't really think about how that translates to a person that never opened a textbook in healthcare, doesn't know a whole lot about anatomy and physiology. We just figure, okay, if we show them the arteries, they'll sort of know what that is. Most people would not know a vein versus an artery. So it's not really clear in terms of how that applies to their situation. But I guess that sticky hand does look a little unappealing. So that would be the attention getter to say that
absolutely.
it may not look like green gunk, but it is the equivalent of that inside of a very, very small aspect. Veins and arteries are not that wide, so they can clog up relatively quickly.
Absolutely. So what we've done then with these missing parts, the incomplete parts, the uninspiring parts, we have created packages. You used that word earlier. We've created care kits so that we can put all together in one place the missing pieces, the incomplete pieces, the uninspiring pieces, and try to make up for those missing things by putting them into one package that a patient would get either at discharge, or their health plan might deliver it to them, or their home health nurse might bring it to the house.
Right. Let's get into those, because I'm very practical. When I first saw these, I did not understand the ethnographic work that Sylvia has just described. I was like, gosh, this looks really good, because as I was a nurse in clinical areas, I would want to have this, something that I could put my hands on, give it to the patients, go through it with the patient and family together. So I was thinking, this is like such a great idea. Now, it isn't QVC that we have here, and I am not endorsing this in any other way other than from my own professional perspective. There are ways that we will tell you that you can acquire these kits if you are interested, but I personally get no remuneration from this. I am just excited about it because I think it is the best example that I have seen thus far of really helping people to take better care of themselves. And it helps us as providers to have such tools. So let's talk about something that many people have experienced firsthand, and that is post-breast surgery. Now, typically, this is what is referred to as a post-acute kit. Translation, you're in the hospital, you've had some kind of a procedure. This is just one example. They have them for many other procedures. But what Sylvia is going to show you in just a moment is what happens at the end of most hospital stays. By the time you're doing the discharge, you're running around putting things together, and you're putting them in a bag, and you're giving them to the patient with very little explanation, and then they're home on their own trying to figure it out. So very briefly, tell us about this breast kit.
What we have in the post-breast surgery kit is everything you need for the time that you will need to recover from the wounds from surgery. The most important part of this kit is we were commissioned to make the kit because people were getting complications and infections from the drain that was hanging out of their body after the surgery. What happened in the hospital was that nurses would pin the drains to people's underwear, which was fine while they were lying in the hospital bed. But once they got home, that was not a good solution. They had a loop of tubing coming out of their chest, and as they were ambulatory now, walking around the house, they would walk through a door, catch it on a doorknob, and yank it out. So this was not a good solution, just pinning it to the drain, although it seems like a simple one. What we did instead was to design a belt bag using the material of a surgeon's gown, and you can put this drain in the belt bag, and you have two of them in the kit, one to wear in the shower and then one to put on dry after the shower. And we've been able to eliminate the infections and complications of the drains coming out.
That's very good because we're trying to decrease return to hospital or return to anything that you don't really need. So this is very good that you can take better care of yourself.
Absolutely, and we have a lot of very dedicated users of these that have used them for 10, 12 years now.
Good. Now quickly, tell us about this. This is more long-term. This is for a chronic illness, and this particular kit is for cholesterol.
Bringing down your cholesterol. Another thing we discovered that was radically missing from the way people were prepared for self-care was the tools that you would get from the hospital, a sheet of paper, and then you were expected to go to a drugstore or some place and buy the tools that you needed. We found that people were at a loss of how to find the tools, or even if they knew at the time when they come home from the hospital, who's going to go out and buy it?
Right.
Someone has to be left alone.
Right.
So part of the packaging in a kit is to put all the tools together that you need so you can instantly start your self-care with no delays.
Right. So for instance, this is a blood pressure kit. This is a pill manager. This is your pedometer. This is your log book so you can know your numbers and keep track of them. And then there is a whole ethnographically designed explanation of what cholesterol management entails that, again, uses the metaphors and the pictures to make it very interesting and engaging. Now, let me just comment on this. Most people think that cholesterol management is basically take the pill, which we just said people may or may not do. This is really the other piece of it, and that is lifestyle management. And this helps you to do a better job of your own lifestyle management, which is very, very important, as important, quite frankly, as the medication. So this really gets you on track on how to really take care of yourself. Now, from the provider perspective, I felt that when I was a public health nurse, I would ask people to go out and get these materials, and I would make multiple home visits. They still hadn't quite gotten it together. So I see it as really a positive thing. These kits really are not that terribly expensive. And I'm going to ask in closing if you are interested, Sylvia, how would people get a kit?
We have a website, which is carekit.com. Simple as that. You can come to that website. There's an 800 number there. We have nurses on staff to talk about which kit is most appropriate. And we would love to have you visit the site.
Very good. And you can also get a link to that particular site on my website, www.drnancyrn.com. Sylvia, I want to thank you so much for being with us today. It's been a delight not only to learn about your materials, but also to learn about all the deep research that has gone on in back of really producing these. These were not just whipped together. This is really the result of a lot of deep work with many, many people in many different circumstances. So again, thank you, and I want to thank our viewers for being with us today. Have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.